I'm Lisa Peterson from the Epilepsy Foundation of Minnesota, and I'm the Regional Outreach Manager in Northern Minnesota. This presentation is provided by the Epilepsy Foundation of Minnesota, a local nonprofit organization that serves Minnesota and Eastern North Dakota. The Epilepsy Foundation of Minnesota is an affiliate of the National Epilepsy Foundation. The Seizure Smart School Nurse training is 90 minutes in length. A certificate of attendance will be shared after the training. If you have questions that come up throughout the presentation, you can feel free to reach out to me afterward. You'll see my contact information listed on one of the final slides. Today's objectives include define epilepsy and seizures, identify the 4 leading types of seizures, learn the appropriate response to seizures, increase knowledge of available treatment options, and gain comprehensive information about supporting students with epilepsy and seizures. So on this slide about getting started, we'll cover a little overview of what we'll be talking about today. So effective management of seizures begins with recognizing seizures, observing them, and documenting what we see. This can be challenging because the symptoms may be difficult to detect at times, occur without warning, and they might be confused with behavioral or psychological problems. So as we talk about the different types of seizures today, we'll address some of these challenges and ways that the school nurse and others that work with students can be effective at recognizing and responding to seizures. So let's begin by talking about what epilepsy is. So epilepsy is a neurological condition characterized by unprovoked recurring seizures. You may also hear it called seizure disorder or seizure condition. However, we most often refer to it as epilepsy, and it's the way that most people will find information if you look it up. And so know that you can definitely use these words interchangeably, but you'll hear us refer to it as epilepsy. So when we talk about seizures that are unprovoked, we're speaking about seizures that recur. So there's something in the brain misfiring, leading to that individual having 2 or more unprovoked seizures. So an example of a provoked seizure would be someone has a near drowning event and they have lack of oxygen to the brain. That could lead to a single seizure, another one after that, and that could be all that ever happens. That person does not have epilepsy. Also, an individual as an infant or a young child might have a high fever and then have a seizure as a result. We refer to those as febrile seizures. And if the individual seizures only happen in the presence of a fever, there's nothing else going on, even if they have more than one febrile seizure, it's still not epilepsy. Or maybe they have a condition like diabetes that can lead to a seizure. So there's nothing happening neurologically leading to that. So we'll talk in a little bit about things that can lead to epilepsy. And so there are times that other conditions can lead to a diagnosis of epilepsy, but the key distinguishing characteristic that we're talking about is someone having a misfiring in their brain leading to the condition that we call epilepsy. So anyone can have a one-time seizure. We all have a seizure threshold. Given enough stress, anyone could have a one-time seizure. Also, drug withdrawal can lead to seizures, or even alcohol consumption, which lowers your seizure threshold. And so again, there are a number of things that might lead to someone having a single seizure at some point in their lifetime. And so today we'll be talking about epilepsy, and we'll talk about how to respond to seizures. So in those moments, even if it's a one-time seizure, how we respond looks pretty similar. And so the information that we'll be learning today will be applicable to both seizures that are due to epilepsy as well as those that may not be. So let's talk about some key facts about epilepsy. Now, you can't catch epilepsy by being around someone else that has epilepsy. But there are still a lot of myths out there. A lot of stigma still exists today about epilepsy because people often have the wrong information about what epilepsy really is. It wasn't that long ago that having epilepsy would have meant something very different to individuals. So it was common practice at one point to be institutionalized, to be forbidden by law from being married, for being sterilized. So know that even in the lifetime of some of the individuals that we work with today, they have memories of those very things happening to people close to them. And so not surprising, people are sometimes afraid of what they don't know, and grateful that we live during a time where we openly talk about epilepsy and have much more information, but there's still a lot of myths. Another myth that people hear sometimes is that you can swallow your tongue. You cannot swallow your tongue. Your tongue is a muscle attached to the back of your mouth. You will not swallow it. Although you might bite your tongue, the tongue will heal. And so if you hear someone say, put something in their mouth during a seizure, know that that's a myth. That is not true. We should not do that. It could hurt their teeth, or a piece could fragment off and they could choke on it. Some other things that people might think is that epilepsy is mental health related. And so we want to be very clear that epilepsy is neurological, not a psychological condition. However, we also know that about 50 to 60% of people who have epilepsy also will have a mental health condition at some point after their diagnosis. So we do know that depression and anxiety could be an impact that that individual with epilepsy also has. Also, epilepsy exists on a spectrum, and sometimes people might think of epilepsy in accordance to maybe someone that they've worked with in the past, someone that they know who has epilepsy, and that might be all they know about how epilepsy can manifest. Now, epilepsy doesn't look the same in each person. You might work with one student whose seizures are well controlled and they haven't had a seizure in a long time. They still have epilepsy, even if they're not having seizures. You may have a student on the other end of the spectrum who's having seizures every day, maybe even multiple seizures every day. They also have epilepsy. There are some kids whose seizures are happening even when you can't see them. Their doctor might, order an EEG test where they wear electrodes on their head and they're able to detect the misfirings when they happen, and determine, how often their seizures are happening. And sometimes people find out that seizures are happening even when they're not aware of it. And so thinking about how that might affect your students, if you have a student who's having a lot of seizure activity, there's going to be a very different impact than on a student whose seizures are under control. And also thinking about their other factors like their medications and side effects and how that may play into how they're feeling and functioning within your classroom and at school. So just thinking about the wide variety of how epilepsy impacts individuals, we know that it's important to keep an open mind to how seizures look and how they impact those who have the condition. It is rare to die from having a seizure. And although it is rare to die, it is something that we should talk about because it can happen. And we'll talk in a little more depth in a following slide that covers SUDEP. SUDEP stands for Sudden Unexpected Death in Epilepsy. There are other reasons why death could happen related to epilepsy, including status epilepticus, which means a long seizure or a seizure that doesn't fully resolve and the individual goes into another and into another. We call those clusters of seizures. Also, the individual could have an accident as a result of a seizure. It could be a car accident or some work-related accident or something at home, or it could be a complication related to the seizure. So there are a number of things that can happen during a seizure, such as aspiration, suffocation. So we definitely want to be thinking about safety, but we don't want people to live in fear of epilepsy. And so as we talk about seizures today, it's important to remember that we're learning about how to respond in a calm way, how to help someone, and remembering that death related to epilepsy is rare, but we'll talk about ways to stay safe and to help individuals who have epilepsy really live their best life. So let's talk about the prevalence. People are often really surprised to learn that epilepsy is common. 1 out of 26 people will develop epilepsy at some point in their lifetime. 1 out of 10 people will experience at least one seizure. And as I mentioned earlier, anyone could have a one-time seizure. Approximately 54,000 people in Minnesota have epilepsy, and approximately 200,000 new cases of epilepsy and seizure disorders are diagnosed each year in the United States. And if we know that 1 out of 10 people will have a seizure at some point in their lifetime, we know that 10 out of 10 people should know how to respond to a seizure. And so we're so grateful that you're having this training today and that you'll be one of those individuals in the community that will be prepared with how to respond to someone who's having a seizure. Epilepsy is the 4th most common neurological condition right after migraines, stroke, and Alzheimer's disease. It is a leading brain condition in children. 1/3 of people who have epilepsy live with uncontrolled seizures. Adults with epilepsy are more likely to have 4 or more co-occurring chronic conditions. Some of the chronic conditions that might come alongside epilepsy include mood disorders like anxiety or depression, ADHD, migraines, sleep disturbances and disorders, and autism. And these are just some of the comorbid conditions that you might see with epilepsy. Related to epilepsy and demographics, here are some things to know. People with low economic status are 2 to 4 times more likely to have seizures. African Americans and those who identify as Hispanic or Latino are nearly 40% of people diagnosed with epilepsy. 1/3 of children with epilepsy live in food insecure homes, and 50% of adults with active epilepsy have an annual family income average of less than $25,000. So people often want to know, why does someone have epilepsy? Well, the causes can be hard to pinpoint. In fact, 60 to 70% of those living with epilepsy do not have a known cause. And it could be a number of reasons why we don't know why. It could be that we just don't have the technology at this time to make that correlation. Too much time may have passed since whatever it was that led to the initial epilepsy for us to make that correlation. And so there isn't always enough information available to come up with the cause, or it may be available to that individual at some point in their life later. For instance, I was 22 when my epileptologist showed me an image of my brain from an MRI and was able to point out that my right front temporal lobe is underdeveloped. It only grew to about half of the size of my left front temporal lobe. And so he was fairly confident from what he could see that my seizures were related to a brain abnormality. So something that happened in my brain development prior to being born. And then I had brain surgery at age 22. And then that information that he shared was confirmed. And so I was 21 years into my seizure journey before I knew the why part. And so we do know that that why may come at a different point other than when they're first diagnosed. It could be a brain infection. So maybe the individual has had a brain infection like meningitis or encephalitis, or maybe they experienced brain injury at birth. So forceps for delivery or lack of oxygen while being born. And as I mentioned, changes in brain development or a brain lesion or a brain tumor. And so sometimes people don't make that correlation that they have epilepsy. I've met individuals who will tell me, oh, I have a tumor and now I have seizures, but they haven't connected the dots and figured out or maybe their doctor hasn't explained it in those terms, so they don't realize that that is epilepsy. Similarly, somebody may have experienced a head injury and as a result start having seizures. So even though the head injury happened, and that's one issue, now epilepsy could be a byproduct of that head injury. So a couple of things to note. The individual could have a single seizure related to that initial blow to the head. So maybe they, for instance, were in a car accident and they have one seizure from that initial injury. If they don't continue to have more seizures, they may not develop epilepsy. It could just be a single event. Down the road, the person, even years after the head injury, may start having seizures. They start having 2 or more unprovoked seizures. Then they'll order some testing. Usually we're able to get some information from testing to be able to see what's happening in the brain. And that's when that diagnosis will usually come. And so it could be something related to that head injury, or they've had a stroke. Not everyone who's had a stroke will start having seizures, but it is something that someone who's had a stroke should be aware of. And then another thing to be aware of is that an individual who's having a seizure that doesn't stop on its own, so status epilepticus, can also lead to that individual having a stroke. And so that would be something to be cognizant of with why it is so important for that individual's seizure to be under control, because it can lead to a number of complications, including stroke. And I mentioned this earlier when we talked about the myths, but there's this huge spectrum of how epilepsy might impact an individual. So as you're working with students with epilepsy, be aware that where they're at in that journey can look different from one student to another. And it can also look different for that individual as time goes on. Maybe that student as a young child has pretty good seizure control, and then they hit puberty and things change. And now it's harder to get their seizures under control, or as they're growing, their meds might need to be adjusted. So there's a number of factors that could play into where they're at, what their seizure control looks like at that moment. And with increased seizures comes an increased risk of SUDEP. And so it is incredibly important for individuals with epilepsy and their family members and their doctors to be having really serious conversations about how do we do everything we can to help that individual obtain the best seizure control possible. Because we know that it's not a one size fits all, and it's not always going to be easily attained, but it's always the goal is for that individual to have the least number of seizures as possible. And another reason why in the school setting, it is so important for that documentation and that awareness, because if the student is in a classroom where people aren't recognizing seizures that are happening because maybe they're not really obvious, so they could be more subtle, it could lead to underreporting how often seizures are happening, which could increase their risk as their seizures are not being documented and the doctor is unaware that they're even occurring. So let's talk about what a seizure is. So when we think about a seizure, think of it as an electrical storm in the brain. So the person who's having a seizure has a storm happening in their brain, and that area is misfiring. And so there's just too much electrical activity, and that could be happening in a small part of the brain, which we would refer to as a focal seizure when it's in a very specific location, or it could involve the whole brain, and in which case then we call it generalized. So you'll hear us use 2 main categories when we talk about epilepsy. So seizures can be either focal or they can be generalized. And so a seizure is an event, and individuals who have epilepsy always have epilepsy. They sometimes have a seizure. So I equate it to thinking about any other medical condition. So if you, for instance, live with allergies, you always have allergies, but there's only certain times that your allergies might flare. Or if you have asthma, maybe most of the time you're breathing pretty well, but when your asthma kicks in, you might have a hard time breathing. You might need an inhaler. So thinking of epilepsy in the same context, epilepsy being the condition, a seizure being the actual event as a result of that condition. Now, I mentioned earlier that seizures can happen in isolation. And so remember that some seizures are epilepsy, some seizures are not going to be epilepsy. And I also want to take a moment and mention that some individuals have what we refer to as non-epileptic events. You might see it shortened as NEE. And sometimes they're also called non-epileptic or non-epilepsy seizures. So things to know, they are legitimate and real no matter what the reason. They don't always require medication, although they might be taking an anti-anxiety medication, or they might be receiving counseling. It doesn't necessarily mean that it's connected to abuse or a mental health issue. The individual might have experienced PTSD or some other mental health related issue, but it's varied from person to person. Our goal is to maintain the respect and dignity of all people having seizures and to promote people having a good relationship with their medical team. And so if that person's seizure is not epilepsy and it's a non-epilepsy seizure or non-epileptic event, the way that's usually determined is through that testing that I've mentioned earlier, where they would glue electrodes on, and hopefully if they see a seizure happening and can capture that and don't see any misfiring happening, that's how they would make that determination that the person's seizure is not epilepsy. So again, it's not fake, it's not on purpose, it's involuntary. Sometimes you might have previously heard these referred to as pseudo or psychogenic, and sometimes people will then make an assumption that it's not real when in fact it is. The experience is very real for that person. It's just that the cause is different and the treatment as well. And one other thing to note, some individuals have both epilepsy and non-epileptic events. And so if you work with an individual who's having both, you may over time become familiar with their seizures and be able to differentiate. But the key is to know that how we respond, how we support and help that person should look pretty similar regardless if their seizure is epilepsy or a non-epileptic seizure. So we're going to take some time and talk about triggers. So it's really important to be aware of these triggers when it comes to individuals with epilepsy in the classroom. Students with epilepsy are, often relying on their parents or someone else that's providing care for them to help them be on track with taking their medications. So sometimes it's education for the family. Maybe the parents don't know how critical it is for that medication to be taken at a really consistent time every day. And so we recommend things like using a pill box, setting a timer, having a note, do something to remember. Also, managing stress and anxiety is a key factor to seizure control. Those living with epilepsy can sometimes connect the dots and realize that their seizures typically happen when they're under a lot of stress, or maybe they're not getting enough sleep, or they're really worn out and they're fatigued, or maybe they are experiencing some hormone changes related to puberty or menstruation, pregnancy, menopause. Anything hormone related could increase seizures. Alcohol, as I mentioned earlier, can lower your seizure threshold, and recreational drugs can lead to seizures as well. Drug interactions could be something over the counter, or it could be something prescribed by a provider. And so an important conversation would be to talk with your provider or your pharmacist before starting a new medication. One that I'm aware of is Benadryl, which has the ability to lower your seizure threshold. So for instance, if the person has epilepsy and they also have allergies and they might need to take something to manage an allergic reaction, it would be an important conversation for them to have with their provider about what the best option would be to take in the event that they would need something. So a little bit of pre-planning could go a long way. Overheating or dehydrating are some other triggers. So some individuals are able to notice that seizures happen while getting in or out of the shower or in the bathtub. And so If the individuals had in the past seizures in the tub, maybe the parents are very aware of that, in close proximity, supporting that individual and being aware. We recommend a shower versus a bath just for safety. Thinking about things like keeping the door unlocked, making sure somebody's in close proximity, able to respond, are all really critical pieces to providing safety for that individual. Poor diet and missed meals are some other potential triggers, and photosensitivity is one that is widely known, but it's really not the most common trigger. In fact, it only affects about 3% of those with epilepsy. For those that do have it, it could be something like a fast action-packed movie, a video game, lights flashing through the trees when the sun is rising or setting. So thinking about that with relation to school safety and riding to or from school in the bus, that could be a vulnerable time for a student, or in the classroom, if fluorescent lighting is used, which is commonly used in classrooms, know that when the lights start going out, they do begin to flash, and those flashing light bulbs could in fact be a trigger for that student. Another thing to be aware of is that when you're doing a planned fire drill, know that there's a lot of flash happening, because some individuals will need that visual cue if they aren't able to hear the alarm going off. So you'll notice that they strobe. So thinking about that, or if you had a field trip planned where you might be going somewhere with strobe lights, or maybe you're watching a production. So just thinking about what could be in your environment if that was your student. The key is really to start connecting the dots. If you have a student with epilepsy, figuring out commonalities. This is not an exhaustive list. Some other things that we know could be a startle response, loud noise. So some individuals really would need some pre-planning for that fire drill, not just because of the flashing lights, but also because of the loud noise. So thinking about that. And then one student that I'm aware of, her trigger was related to an activity she was doing. It was related to math. And so she would tend to have seizures during algebra. Now, you might wonder why. And what was able to be determined was the same area of her brain that she was using to do math is the same area her seizures originate from. So it could be something very specific for your student, not on this common list of triggers. So the key to note is that seizure triggers can vary, and watch for a pattern, communicate with the parents, make sure that there's an awareness so that we can ultimately try to avoid some of the situations that can lead to seizures. And not every seizure is easily attached to a trigger. Some seizures are going to happen regardless. It's not always that just following a certain formula can lead to seizure reduction, but these are important to know as anyone is working with students. So there are phases of a seizure. And so you may have heard some of these terms in the past, but prodrome refers to the changes seen hours or days before a seizure. This is something that's often overlooked when we think about students and seizures. It's not just the actual seizure, it's also the leading up to it. And so they might be out of sorts a bit. They might not be feeling their best. So thinking about how that translates into how they're doing in school, how what their energy level looks like, their ability to attend to a task, all of that could be influenced by their body going through some changes leading up to that seizure. Also, the student might experience an aura, which can be the first symptom of a seizure. It's sometimes known as a warning, most commonly seen with focal seizures. So keeping in mind an aura really is a focal seizure. So they can stand alone in isolation, or it can come as a precursor to a bigger seizure. And so if your student has a focal seizure and it doesn't present as anything else, they might just have that focal seizure, or again, it could lead to something bigger, in which case we would refer to it as their aura. And then when we say ictus, we're talking about what is seen or felt during the actual seizure. So that is the seizure itself. And then the post-ictal state is what is seen or felt after the seizure until the brain fully recovers back to baseline. So you might see changes in their speech, in their memory, and their energy level. All of those are typical pieces that we might see in relation to that individual recovering from their seizure. And so again, it's not just us being there, responding, supporting that student during the seizure, but we want to be aware of leading up to and coming out of the seizure, what we can do to support students. Some things to note regarding behaviors. Seizure behaviors are very individualized, so it's not going to be a one size fits all on what you could expect to see. They're often sudden and unexpected, so we don't always have a lot of forewarning. That individual may have no idea that they're about to have a seizure. Sometimes the seizures can have some common features. So you may notice from one seizure to the next because they may, be coming from the same area of their brain. They might manifest similarly each time, but not always. They can take on different forms. Many people have more than one type of seizure. And there might be some consistency in general length of the seizures, but again, not always. Sometimes they may stop quickly. Other times they might have longer seizures or clustered seizures. In the event that you're working with a student that has frequent seizures that don't stop on their own, there will be hopefully, some attention given to creating an action plan that speaks to that situation and really ensures that there's some safety protocol embedded into that. For instance, I worked with a student who would frequently have seizures that wouldn't stop on their own, and she was far from the local closest hospital. And so taking into consideration the length of time it would take to get paramedics to her school and then for them to get to the hospital, they didn't wait 5 minutes to make that call. Based on her prior seizure history with longer seizures, the protocol was to call for support with 911 right away. And so seizures really can vary in intensity, and they can be impacted by environmental modifications. And so the key to be aware of is just be aware, know as much as you can about the students' prior seizures, but keeping an open mind to how they might vary. And when we refer to environmental modifications, we are referring to things that can help reduce exposure to situations that would trigger that seizure. So again, if you know things about that student that put them at risk, there are things that you can possibly change in your environment to lower that risk for that student. So let's talk about characteristics of seizures. Seizure characteristics may be determined by the age of onset. So while seizures can happen at any age, some ages have a higher incidence rate. So we know that seizures most often start in childhood. There's also different seizure types. And so the classification of seizure types can determine what we might see on the outside or the severity of the seizures. And then the frequency. Some individuals may have many seizures a day, as I mentioned earlier, while others might have seizures less often. And so thinking about this wide variety of how it might manifest, we really want to be cognizant of how epilepsy may impact one student would look very different than how it impacts another student. So on this slide, we're looking at a few pieces that help us ultimately understand and identify the type of seizure that a student is having. So we're looking at where in the brain are the seizures located? Are they focal, meaning part of the brain, generalized, which refers to the whole brain, or is the onset unknown? In this case, it might be that we just don't know enough yet. Maybe no one was there with the individual when the seizure happened, so we don't really know if it started focal and turned into a generalized seizure or if it was generalized right off the bat. And so sometimes we just don't have that information available yet. So the doctors may classify it as unknown until more information is available. We're looking to understand what that person's level of awareness is. Sometimes seizures can happen where they're fully awake. Other times they're awake but confused, and other times they're unconscious. And so there's a range of what their consciousness might look like. And then we're also looking for changes in the individual's movements, in their sensations, in their behaviors, and in their speech. Again, all of these puzzle pieces combined help us understand which type of seizure the person is experiencing. And the doctors are the ones that come to this diagnosis and understanding, But keeping in mind, again, your documentation in the school setting is crucial to the provider having that information. They can do some testing and they can figure some things out through that testing, but they also heavily rely on those who are with an individual having a seizure being able to document what is seen. So we're going to be talking about the 4 most common types of seizures. Now, keep in mind, there's over 40 types of seizures. And so there are going to be seizures that don't fit within these 4 categories that we'll be talking about today. And then even within these 4 types, there's a lot of variation to how they can manifest. So we're going to start with this seizure called focal aware. If someone's having a focal aware seizure, you may previously have heard someone call it simple partial. Simple partial and focal aware are the same thing. The person having this type of seizure is fully aware and they're still having a seizure. And this one can be misunderstood because some people might think that a person having a seizure wouldn't remember what's happening or be aware, when that's not true at all. This person, although they're fully awake and aware, is not in control of what's happening in their body. So they might have uncontrolled movement. This might look like jerking movements in their arm, their leg, or muscles in their face. And it can lead into other seizures. So again, this might be their aura, or it may stop right at that. So it could be uncontrolled movement, or it could be a change in their sensation. So the person might tell you that they smell something burning, or they hear a ringing sound, or they have a funny metallic taste in their mouth, or they see flashing lights in their peripheral. And so there's a variety of ways of how it might look for that person. They might also describe it to you as a strange feeling that comes over them. It might be described as deja vu, doom and gloom, unreality. It could feel like fear or joy or confusion. It is a very difficult feeling to describe. Sometimes people just know that they don't feel right. It's a funny feeling. It's unexplained. And the person experiencing it might be aware that this is not maybe what other people are feeling like. They know something just isn't quite right, and it could be happening frequently for them. And again, if it doesn't lead to something bigger, they may not know what it is. It could be confused with something mental health related. It could be just overlooked altogether. In fact, I went from kindergarten through 11th grade having focal aware seizures that were not recognized or responded to, and I wasn't diagnosed with epilepsy formally again until I was 16 after having a seizure while driving. Now, to back it up, I did have quite a few seizures as a young person that were diagnosed. So I started out with the bigger ones that people usually think of, and we'll talk about that in a little bit as generalized tonic-clonic. There was really no disputing that was epilepsy when I was an infant and through my early childhood years. But because my doctors and my parents and my teachers were unaware of what was happening and how those were actually seizures, it just wasn't something that people figured out. But I was describing it, just not in terms that people understood. So when you work with students, think about the challenges that they might have with putting into words what they're feeling. You know, when I was a kid, I told people I had the chills. I knew I didn't feel right. I knew that when I got that really uncomfortable feeling, that I just wanted to feel enclosed. I wanted to feel safe. And so some strategies that I had found included racing to the couch and piling blankets on me, or I would run to my mom and have her hold me. But at school, I didn't have those options. So what I did figure out is that if I wore my jacket all day, I could just ride it out. And so there were certain days that I would wake up feeling kind of off. Some people will call it a foggy feeling or just an off day. And I would have those days and I would tell my parents, oh, I have the chills today. I didn't think to tell anybody that I had a weird taste in my mouth. It just became typical for me. And I would have these days and my mom would get mad at me and she would say, Lisa, this always happens when you stay up too late with your friends. So she had started to correlate sleep deprivation leading to some of these, but Nonetheless, she still didn't connect the dots and realize these were seizures. So it wasn't until my seizures became a little more obvious that people started to take notice. And so my ask for you and any other person working with students would be not to dismiss when a student reports something to you. One of my clients would report to her teacher that she would smell something burning. And she was a student who had diagnosed epilepsy, but her teacher and her parents didn't define epilepsy in those terms. They only thought about seizures as convulsions. So they weren't getting it. And they would get frustrated and tell her, stop, sit back down, or her parents would tell her, go to your room, think about your behavior. And it wasn't until I visited her school and talked about epilepsy with her classmates in third grade that they realized mom was in the room, teacher was in the room. Wait a second. When she describes that smell, that's part of a seizure too, not just when she's convulsing. And so it can be just a lack of awareness. And it's really critical that those working with students have the broad understanding of what seizures can entail, because if we have a very limited view of them, we're going to miss some things with seizures. Now, this type of seizure you'll see is not typically going to be what we would constitute as an emergency, usually lasting only a few seconds up to a couple of minutes. Key for this person is emotional reassurance. So I told you I felt uncomfortable. I didn't like how I felt. Now, I didn't need a whole lot, but I would have benefited from people understanding and acknowledging and supporting. And so when you think about your students that you work with, recognize how critical that is that you are supportive. I learned that I could self-soothe. I also learned that I really despised being in wide open spaces like the cafeteria, the FIED, the hallway, or recess. I didn't really make a big deal out of it or tell anyone, but in hindsight, I really, you know, intensely remember what that felt like. And there was a really kind woman that worked at my school who was one of the noon supervisors, and she was so just kind. And I would seek her out and I would go to her and she would hug me and she would provide for me the very reassurance I needed when I was having a seizure, having no idea that I was having a seizure or what she was doing to support me during that. And so you may not even realize sometimes what a student is doing, how instrumental you might be. But I share that to really put some context into why this is important to talk about. And we want to remember this often will lead into other seizure types. So may start with this focal aware seizure, AKA aura, or it may just start with something else. So let's talk about when seizures look different. So seizures can be focal impaired awareness. So you'll notice the impaired awareness part gives you a tip that this individual's seizures are altering their sense of awareness. And so with that focal aware seizure, the person can remember what's happening even though they're having a seizure. Now, the individual having a focal impaired awareness seizure will not have a memory of it. They may remember going into the seizure, that focal aware seizure, and they can remember coming out of it. It gets really fuzzy. It's sort of like a dream. The person is conscious, but they're not aware. So I think of it a lot as looking like sleepwalking. So the person could be up moving around, doing activities, and not remembering that they did it. So it's like being on autopilot. Or imagine somebody turns off the GPS in your brain. The part of your brain that tells you where you're going can be severely impacted. So just like you can drive a vehicle and have no clue where you're going, you're lost, you're confused, you don't have GPS, you don't have a map, you're in the middle of nowhere, you have no idea how to get from point A to point B, and you're disorientated. Think of the person having a focal impaired awareness seizure in that light, that they're up moving around, walking, maybe talking, but they're not fully with you. They're really confused. So things that you should look for a blank stare. So look for a glazed over look on their face. So it might start out with this kind of just look of confusion. And then you might see some things like repetitive purposeless movements. So you could see the person picking at their clothes, wringing their hands, blinking their eyes, smacking their lips. Those are all indicators that this person might be having a seizure. It may change their speech. So they might say things or do things that don't make a whole lot of sense to you. Um, but they might be having a conversation. So knowing that it's not always going to look the same. They may be unresponsive to you, or they might not appear to be with you because they aren't. They don't fully understand what's going on. And if you get in their space, they might appear agitated. So they might push, they might flail. And so it's especially important for us to not escalate the situation, not make the situation worse. So we're looking for a change in their awareness, a change in their speech, looking kind of glazed over. And again, looking for changes in just what's happening with their, how they might be responding to situations. Usually these will stop within 1 to 3 minutes. However, they can cluster. So it can become a medical emergency, and they may even have a rescue medication on hand in the nurse's office, because if they have a history of seizures that cluster one after another, they have the propensity of turning into generalized seizures and should be, um, you know, done, supporting that student to make sure that that is acknowledged. And, in years past, it wasn't readily available for students to have rescue meds in the school setting or at home, but we've come so far. And so that's a really great thing that can provide that extra layer of support for students. And so those would be important questions to ask the parents. How long do these seizures usually last? Do they typically come out of them? Do they go back into more seizures? Do they have a rescue medication? If they don't currently have a rescue medication and they're having seizures that are clustered, that is something that their provider should be talking to them about. So on the day that I was finally diagnosed again, it was halfway through my junior year. It started out with that weird feeling, that focal aware seizure, but I didn't feel it right away in the morning. In fact, I thought I was fine that day, and I was waiting to have a day where I didn't feel right to try to get to that diagnosis level, because by then I had been trying to get testing to show that I had seizures. So that particular day, I did go in for testing after having a seizure behind the wheel, and I had on record clustered focal impaired awareness seizure. So I left that day knowing I had epilepsy, knowing that I had cluster seizures, but this was in 1996, prior to the availability for individuals to have that medication on hand. So it was fast forward 6 years later, when I was going through testing for brain surgery, that very similar clustered seizures in the hospital setting while being tested and treated with a rescue med and given a prescription to start carrying it. And so it was a learning experience for me. And I'm sure for many people in very similar situations where they lived with a condition, not understanding some of the risks that they had until that information became available to them. And so, again, you might think of this as low risk, but we do want to take it seriously. So again, what you might see, the person could be up moving. So you might think your student is misbehaving. You might think that your student is just acting out. You could think it's disorderly conduct. You might think it's someone on drugs or drunk. So there's a lot of things that it could be confused with. So from my experience and experiences with my clients, I've heard a variety of ways of the ways they manifest. So to give you some context, I've had clients have these in public settings. Sometimes they're understood, sometimes they're not. One individual was working in his community at a local establishment, and somebody called 911 and misinterpreted his seizure and thought that he was, dangerous, and brought him down with force, put him in handcuffs. And so that could happen. And then these are why we talk about epilepsy, why we want people to understand what it can look like. I have an elderly client who ended up wandering into someone's home and was perceived as a home intruder until somebody recognized who she was and thankfully de-escalated the situation. Um, a variety of settings, people of all age experiencing them in different settings. Thinking back to the way they looked when I was a teenager and started having them, my friends and family members and those around me reported to me what they look like. But remember, you don't remember it. You don't have a memory. You'll just feel kind of off and have a headache afterwards. So one setting, I was picking up my clothes, saying I was cold, grabbing the girl next to me. Another time I was in the hallway and my friend recognized that something was wrong with me. She saw a glazed over look on my face, knew to stay with me. She later on caught up with me and reported how it played out. And apparently, I could hold a conversation, but I wasn't really with her. So I couldn't tell you what hour of the day it was or how to get to my class. So she was able to draw some of that information out of me as far as where I belong in third hour. But she said my navigation was off. So I couldn't have gotten there without support because I was wandering in the wrong direction. So thankfully, intuitively, she just knew to stay with me, guided me to my class, and did exactly what I would hope someone would do. But unfortunately, none of my teachers at that time knew I had epilepsy. The nurse wasn't aware of what was going on. So I functioned through that day coming out of a seizure, feeling really off. I mean, my head was pounding. I was really fatigued. And no one knew to support me because no one knew that I had just had a seizure. I just remember feeling like everything was a little surreal that day, coming out of it. When I was finally diagnosed and able to understand it better, I would educate those I was closest to. And my employer at the time when I was 18, I was cashiering, and my manager on duty responded to my seizure. A customer found her, reported that instead of giving him change, I started telling him I needed to save money for college. So clearly, like, you are on autopilot during this seizure, you don't know what you're saying or doing. I have no memory of saying that to him. And thankfully, she quickly discerned that it was a seizure. And because she has two family members with epilepsy, she was really acutely aware of what seizures can look like and was able to wait for me to fully come out of it, respond with calmness. And those are really kind of best case scenarios, is when someone understands it, recognizes it, and provides the right level of support. So we are going to watch a brief video on what it might look like. And then we're going to talk about what you can do if you see someone having this type of seizure. Keeping in mind, this is the most common type of seizure, which is why I'm really trying to emphasize the importance of understanding it. Because of all the seizures you're going to see, this is the one that is most likely going to be the one that you would be seeing in the school setting. So you saw in that video a few different things that might, be happening during this type of seizure. You might see somebody with repeated movements, like he was tugging and grasping on his shirt. You might see walking movement that's altered. In this video, you might have noticed a person staring to one side while moving, not responding appropriately when someone is speaking to him. And keeping in mind, these can vary. And so, my experience with them for myself, from what I understand from what others have described, isn't a lot of shaking during this type of seizure, but just the repetitive movement. And so you may not see shaking. You may just see a person being really confused and out of sorts. So, just try to remain kind of open with your thoughts on what you might witness during this type of seizure. So the person needs from you to stay calm, track the time. So if you have a phone, you can use your phone to track the time. Do not restrain the individual. By restraining them, you're going to get them pushing and flailing, and it'll escalate the situation. And well meaning people sometimes restrain and they think they're doing that person a favor. In fact, when my husband and I were dating, and I had a breakthrough seizure 3 years after no seizures, and I was feeling pretty confident, felt funny that morning, didn't want to make a big deal out of it. We were on our way to a camp I used to work at, and I just didn't want to feel it that day. I'm like, nope, it was so, close to having, gone such a long time, and thought maybe I had this thing licked. And so I felt funny, was feeling that aura, that focal aware seizure. And then when we arrived at the camp that I'd previously worked at, I was in the parking lot when I went into this next focal impaired awareness seizure, and he reported that I was picking up my clothes, similar to some of my previous ones, but while not understanding that holding or hugging, or trying to be, supportive may not be the right answer. So I remember coming out of the seizure. I remember pushing and like not like intentionally, but I kind of remember being like startled and kind of like, let go, what's going on, and being caught off guard and saying, what's going on, what happened. And then he and my friend who was waiting for me to arrive were able to, articulate, hey, you had a seizure, you weren't responding right away, you were picking at your clothes, this is what was going on. And I didn't want to believe it. And so no, that could happen. The person having the seizure, because they don't remember it, and you're now telling them this is what you said, this is what you did, they're not going to be agreeable with you necessarily because they don't remember it. And they're maybe really disappointed that another seizure happened, especially if you're working with a student that is a little older and more aware of what's going on. And it could mean their driving privileges, which it did for me at that point. And so a lot can be going on for that person. And so you really don't want to restrain, even though you feel like hugging, holding, supporting feels natural and like the right thing to do, you'll do more harm than good and potentially make the situation worse. So sometimes people restrain because they think that they're, the person's dangerous, which is not true, or they might be restraining trying to provide comfort. What would be a better option is to either block them from danger or don't touch them at all if you don't have to, because maybe they're not in danger at all. They just need you to wait it out. Or if you see them in danger, maybe they're walking toward the street or something sharp or dangerous, then guide them from behind. You want to avoid things that are dangerous for them. So like traffic, a hot stove, a flight of stairs, anything that could hurt that person, certainly guide them away, stay with them, remain calm, be reassuring. And again, be cognizant of what are they feeling like? What are your words going to sound like to that individual when you're explaining to them that you're here with them, that they've had a seizure, they're going to be really tired, have a headache, possibly just need some time to rest. So remember that they're not going to be in a great frame of mind to have a conversation with you. They will want to be able to lay down. That's their body's way of resetting after a seizure. So allowing that individual in that post-ictal state coming out of the seizure to have the space that they need to recover from their seizure. So absence seizures are generalized, including the whole brain, used to be called petit mal, brief, sudden lapses of awareness characterized by brief staring or rapid facial movements, quick return to typical awareness. So usually these seizures will last about 5 to 20 seconds in length, and they can be confused with daydreaming or attention issues. The important pieces for you to know are to track and document the time, keeping in mind that these seizures can be very brief. You might miss some of them, but as much as you're able to document so that the parents and the medical providers understand how often they're happening in the school setting. And remember that students having this type of seizure may not even be diagnosed right away. They often onset between the ages of 4 and 12. So they can show up at any age, but often are going to start in those years of, elementary school. And it can look a whole lot like other things. And so I've heard from many of my clients over the years that years go by before they connect the dots and figure out that their child is having seizures. So sometimes it's parents starting to document, other times it's the teachers figuring it out. Sometimes it's because the school personnel training has happened, and it could be either the nurse or the teacher or the paraprofessional or someone in the school who's working with that student that all of a sudden realizes, wait a second, this kid who doesn't answer sometimes, who doesn't seem to be paying attention, maybe they are having a seizure. And so some red flags might be you say their name and they don't answer you because they can't hear you. They can't respond until that seizure's over. So it can really be the documentation. You don't have to be a doctor. You don't have to be a nurse. Anyone can be useful and supportive in helping identify that seizures could be happening. And so the hope is then that those working in the school setting feel empowered to document and share their observations, which can be used by the healthcare team. And so I could tell you story after story of schools that have shared the impact. And so I know how important it is for educators to be informed. And I hope that, the fact that you're having this training is really, speaking to the fact that you want in your school for that recognition to happen. And so let's watch a short video of what it might look like and how we can, again, support a student who's having this type of seizure. So you might have noticed that she just all of a sudden cut out of the conversation, then she jumps right back in. This can happen off and on throughout the day. Some students will have eye blinking, other times will have some chewing motion or some, even a facial twitch. So there can be a number of things that you can see happening with that individual. So again, or even heavy breathing. So looking for changes in their eye movement and their breathing, in their awareness, and they start and end abruptly, and they may pick up in a conversation as if they never left that conversation, and they may turn into bigger seizures. So they don't always stop right away. So we're going to switch gears now and talk about generalized tonic-clonic seizures. So generalized tonic-clonic seizures involve the whole brain. These were formerly known as grand mal seizures. So if you hear it called grand mal, no, that is not the preferred term. Grand mal means big bad. And so you might guess it's not how we want them referred to as. Generalized means whole brain, tonic means tightening, clonic means shaking. Things that you might see during this seizure include a sudden cry or a moan, like a guttural gurgling noise, a loss of consciousness, a fall to the ground, tightening of the extremities. So the arms or the legs might tighten up, or the body will tighten up. And then you might see some rhythmic shaking on both sides, or known as the clonic stage, that shaking or jerking part. So not everyone goes into the clonic stage. You might be working with a student who's having a generalized tonic seizure, they tighten up, and then they don't go into the clonic, their body just eventually relaxes and the seizure ends. Or they might go back into the tonic stage. So an individual who's been going through the rhythmic shaking and jerking may tighten back up. So just know there can be some variation to the pattern of how it can look. Usually these are going to be brief, lasting 1 to 3 minutes in length, but they can last much longer, and anything more than 5 minutes is considered a medical emergency. My first seizure as an infant lasted over 2.5 hours. And so my parents learned right away that seizures can last a long time and that they can be medical emergencies. And so the key is for people to understand what's typical and what warrants an emergency. So we're going to be talking on one of the upcoming slides about how to differentiate when it's an emergency and what to do. But these are typically going to be short. The person might feel tired afterward. They might feel sore and confused. So that post-ictal state can take a while to end as they're recovering. So give that individual the time that they need to recover from their seizure. So you can see from the video and from this slide, a couple of the things that we'll be talking about. So always turn the person on the side. You saw that in the video, you see it in this visual. What you might not have seen in that video is maybe there was someone timing that seizure, which is really important. We want to know when it started, when it ended. So it could be the person who's responding to the seizure is also timing it, or there might be two different people, supporting. So you might be in charge of timing. Someone else might be right there on the ground supporting that person by getting them on the side, cushioning their head. That could be a pillow, blanket, jacket. If you have nothing soft, use your thigh, cup your hands. You could be clearing the area, so removing desks, tables, chairs, pushing stuff out of the way, loosening tight-fitting clothing, taking glasses off so they don't shatter, or staying with that person until they are fully aware. So there's a number of things that you might be doing. You might also be thinking about the audience at that moment. So thinking about your classroom and what can you be doing? Maybe asking your students to line up. Maybe they're going to another classroom or in the hallway to provide privacy to that person. That person having the seizure may experience a loss of bladder or bowel activity. And so thinking about their dignity and their respect is really important in how you can maintain as much privacy as possible. We also want to empower students to step in and help. It's why we visit classrooms. So know that maybe it's the students who were first there helping and supporting their friend, but once the nurse is there and the teacher and any other adults who are there supporting that individual, then you can kindly let the students know, thank you for helping, and we've got it from here, and letting them know how much you appreciate the help that they provided until the right people were there. And so it will look different from case to case, depending on where it happened, who was there at the time. But these are just some general guidelines for what to do. You might have an action plan that states things a little bit more explicitly on what to do to support your student. And so it's important to know that action plan and how you should be prepared for helping a student in the event of a seizure. So there are additional generalized seizure types that you might be aware of. Myoclonic seizures are rapid, brief muscle constrictions that it can occur singly or in clusters. They can affect certain muscle groups on one or both sides of the body. So they might just have a sudden tightening of their muscle, just seen as like a sudden muscle jerk, maybe their arm or their leg. So they be aware of that. There can be tonic seizures that are bilateral. So the stiffening or the posturing of the body, so tonic only, maybe not leading into that clonic stage, or an atonic seizure known as a drop attack seizure. It could lead to a loss of tone, muscle tone. It might result in a drop of the head or the trunk or the whole body. And so it can look like clumsiness or a fall to the ground. And so there are different ways that it might look. And if they are having frequent atonic or drop attack seizures, they may be wearing protective headgear like a helmet to prevent injury. And so most seizures are brief. Ultimately, we're looking to keep that person safe from injury and reassuring and documenting. And so be aware of the potential other seizure types that your student might experience. If the student has a seizure on the bus, similar to at school, you want to keep them safe. If they were to have the seizure that, in a seat facing out would be the best option, or in the aisle, there isn't a lot of options with moving furniture or moving people. And so you do what you can with the space that you have. If they're having a focal seizure, you'd want to stay with them, observe them, providing support just like you would if you were in a school setting. And then following their standard protocol, it might be getting in touch with the parents or the nurse and figuring out if someone's arriving to meet you where you're pulled over, or going back to your school or to their home, whatever that looks like, and depending on whether or not it leads to an emergency or if it stops on its own. So there's all that information that should be included in their action plan that should be indicated, just like what you should do in the school setting. In a wheelchair, safest options are putting the wheelchair brakes on. If it's a tilt wheelchair, tilting the seat back and locked in position, leaving the person seated with the seatbelt fastened so they're not going to fall out, but making sure their breathing isn't restricted, supporting their head until the seizure has ended, and leaning the person slightly to one side if they're having a convulsive seizure. And I think I didn't mention it on the slide with what to do, but you always want to get their head to the side. Reason being is saliva can pour out, vomit can pour out. So it's why we want their head to the side, and contrary again to old belief, you're not going to swallow your tongue. And so again, nothing in your mouth. So key is just to get them to the side so gravity will pull the tongue down. And you never want to restrict movement for anyone, whether they're, in a wheelchair or they're on the ground, because restricting their movements could damage their bones or muscles. And so if they're in a wheelchair, you want to make sure they have freedom of movement of their limbs so they don't become injured. And so we really just want to be there, support that person, and keep them safe in whatever way that we can. In the water, supporting the head so their face is above the water, tilting their head back to ensure a clear airway, removing the child from the water as quickly as can be done safely. And if they're not breathing, absolutely CPR should be administered, and always transporting the child to the emergency room, because even if the child looks like they fully recovered, they may have aspirated some of that water and it could cause some serious complications. And so we want to make sure that it's treated like an emergency. So generally speaking, these are protocol, guidelines for when to call 911. Anytime it's the first seizure or the first one we're aware of, if they become injured, breathing stops or does not come back to normal longer than 5 minutes. And again, that's referred to as status epilepticus, or if they cluster, if the seizure happens in water, if they have another underlying condition like heart condition or diabetes, or they are pregnant, or you're not comfortable, or whatever their action plan states on when to call 911. Those are all reasons why someone should call 911. So status epilepticus is medically defined as 5 minutes of uninterrupted seizure activity, which may include one prolonged seizure or multiple seizures without recovery to baseline, again known as clustered seizures. Medical emergency requiring immediate action to stop the seizure activity. So it is really important that we treat it like a medical emergency, and their action plan should clearly define what constitutes a seizure emergency for this child with a detail of an emergency response plan. Death in epilepsy, as I mentioned earlier, is rare, and and most seizures are not going to be an emergency if they're responded to appropriately, but people can die due to complications from a seizure like status epilepticus or from accidents associated with the seizure. The most common form of death in epilepsy is SUDEP, known as sudden unexpected death in epilepsy. And this applies to the sudden death of someone who has epilepsy in the absence of an obvious cause. It is, research. SUDEP Institute is a great resource where you can learn about the research and the resources available for those who are looking to be proactive, and also support for those who have lost someone. And what is thought is that because your brain functioning changes or your heart rhythms change, that sometimes those could be impacts leading to death. And so there, again, isn't always enough information to know. So the risks are 1 in 1,000 people with epilepsy. The risk factors are highest in people with uncontrolled seizures. Epilepsy beginning in childhood between the ages of 20 and 40 is a high risk time. Having epilepsy for a long time, not taking medication regularly as prescribed, and having seizures at night, known as nocturnal seizures, are all risk factors for SUDEP. So refractory epilepsy is also known as uncontrolled, intractable, or drug resistant. This is a situation that is challenging and impactful on everyday life. Seizures can be uncontrolled for several reasons, including incorrect diagnosis, incorrect treatment, triggers, or lifestyle choices that affect seizure control, or properly diagnosed seizures do not respond to the best medical treatment. It's also known as drug-resistant epilepsy, and it occurs when the person has failed to become or stay seizure-free with adequate trials of 2 anti-seizure medications. There are some severe epilepsy syndromes to be aware of, including Dravet syndrome. It's a rare drug-resistant epilepsy that begins in the first year of life in an otherwise healthy infant and is lifelong. About 80% of cases are due to severe SCN1A gene mutations that affect the sodium ion channel function of the brain. It's characterized by frequent, often severe and long-lasting seizures, and the seizures can be very easily triggered. Most children develop varying degrees of developmental delays and the dependence into adulthood. And so there's just a lot of variation to seizure types, and knowing if they have a severe epilepsy syndrome can make really a different impact on how that might look for your student. Lennox-Gastaut syndrome, it's a severe form of childhood epilepsy with multiple types of seizures, persists through childhood and adolescence into the adult years, and has intellectual development delays as part of it in most cases. And then finding the correct treatment can offer hope and help. So it can be especially important for students with LGS to have that, team that's really supporting them and finding the best treatment available to them. I mentioned earlier the psychogenic non-epileptic seizures, known as PNES or NEEs, may look like epilepsy-related seizures, but they're not going to show up on an EEG. And so again, diagnostics can be used to help understand what might be happening for that individual. And it could be a number of psychological factors, as I mentioned earlier. And so just know that the treatment options will be assessed sometimes by a mental health provider. And then looking at treatment options for epilepsy, medication, brain surgery, implanted devices, diet, and medical cannabis are all options that we will discuss. So medicine is the primary way in which seizures are controlled, and it's almost always the first therapy. Different medicines help with different kinds of epilepsy and seizures. Medicine controls about 7 out of 10 people living with epilepsy, but that also means 3 out of 10 people are still struggling with seizure control. It is important to never stop or change medication without consulting with a doctor. So you can see from this slide that seizure control can vary with each subsequent medication change, and that the seizure control becomes less likely. And so once someone has failed the med and now they're onto their second and onto their third, you can see that there's only a 1% chance that that individual will achieve seizure control. And so one of the things to note in the classroom setting is that the side effects of the medications can be just as important to recognize as the seizures themselves. So it can lead to tiredness, weight gain or weight loss, cognitive concentration or memory issues, hyperactivity, emotional or behavioral changes. Some of the side effects might get better with time while others persist. So really important to be communicating with the parents about any changes you're seeing at school and letting them know so that they can share with their provider how their medications are working for them, because it's not just about seizure control, it's about tolerable side effects. So tracking side effects, again, is really critical. You might be using an observation record, you might be using an app. So there's all different ways to keep track, but finding out what's going to be used and being consistent is really important. And then know that generic and brand name can work differently. So switching between formulations can be a problem, but just getting on one or the other is usually what is determined. And then so it's important to stick with the formulation that is working for that individual. And then emergency meds, as I mentioned earlier, can be used in situations where a seizure won't stop on its own. They can be given in different formats, including rectal, buccal, through the mouth, or nasally. Really important that they're easy to use, quickly working, safe with little to no side effects, and that it's comfortable for that individual. For instance, rectal diastap may not be the most comfortable option as an individual is growing, and they might be concerned about their privacy and dignity, and hence they may find some of the other options to be a little bit more desirable for how they would want someone responding to their seizure. So again, it's given in different formats depending on the seizure medication. It's important that that plan is included in their seizure action plan, that if someone is delegated other than the school nurse, that administration comes from the nurse, or that delegation comes from the nurse, and that should be clearly identified. That individual should be trained by the nurse on giving that medication if that's the case. And we are glad to support with available resources on different administration options, but really it comes down to the nurse being the responsible one for making sure that any staff feel supported and have that information available to feel prepared. So knowing your school district policies and applicable state and federal laws, identifying any changes in behaviors or seizures does not require a skilled nursing assessment. When a school nurse delegates under the nursing license, it is their responsibility to ensure the delegation is appropriate, provide training and ongoing assessment and documentation of the competence of the delegate, and to have ongoing assessment of the students' health outcomes. and then bringing the parents and school personnel together to develop a safe health plan for that student. And then there are different options. Brain surgery in some cases can help. There's different options, including resective surgery, which I had when I was 22. And it's been almost 19 years and I'm seizure free, but not everybody obtains seizure freedom. Sometimes it's seizure reduction. Sometimes they're still on meds, maybe less meds. Laser guided ablation surgery can be done. Corpus callosotomy, splitting the hemispheres, or hemispherectomy are all different options. So the outcomes will really depend on the individual. There's a lot of testing that goes into determining if someone's a good candidate. And so it's not going to be a quick decision. If someone is a potential candidate, there'll be a lot of thought that goes into that. There are implanted devices, and these devices can help reduce the number of seizures. So the VNS, known as the vagus nerve stimulator, stimulates that nerve on intervals. So you can see it's implanted in the chest, connects to the vagus nerve. It goes off at scheduled times, but they may feel a seizure coming on and they could swipe their magnet over their chest, or if their heart rhythms change, the VNS may detect a potential seizure and provide extra electrical stimulation. RNS similarly provides electrical current. It's implanted in the brain, and it's essentially like having a little EEG test in your head. And as it detects a seizure that may be coming, it will provide electrical stimulation to that area where the seizures originate from. And then DBS, known as deep brain stimulation, similarly provides electrical stimulation to generators each side of the chest, and then the electrodes are planted deep in the brain, in the thalamus area, and given at specific intervals where it's supposed to stop seizures or make them less often. So the area that it's stimulating is an area that is determined to have the ability to hopefully stop or reduce seizures. So case by case on how the seizure control looks, and the outcomes will vary. High fat, low carb diet is called ketogenic, very different from the standard American diet. High fat, low carb or low protein and carbs, limited fluids, includes short periods of fasting, really strict guidelines. And so you can imagine that it's really hard to stick with. A third of people become seizure free or almost seizure free. A third find improvement but still have some seizures, and a third do not respond or find it too hard to comply with. And so know that it's going to be case by case on how that turns out. Medical cannabis, as you may be aware of, has been legal in the state of Minnesota since July of 2015. So the steps to participate include certify, register, and receive. You can see from this graphic. So their seizures are one of 15 qualifying conditions. The product lines include oils, vaporizers, and capsules. There is one FDA-approved medical cannabis-derived medication for epilepsy known as Epidiolex, and it is used for 3 intractable childhood epilepsies, including Dravet, Lennox-Gastaut syndrome, and tuberous sclerosis complex. And then, so it's really going to be, important for that individual who might be considering it to, get the help that they need. There are different options, as I mentioned, available for its how they're administered. Again, there's only one that's approved on the school grounds, which is Epidiolex. And so that can be a barrier for some people. And then just keep watching, because I'm sure that things will continue to change as legislation is looked at and there are updates to protocols. So know that epilepsy impacts people in different ways. And I've been saying this throughout the presentation, but it's not a one size fits all. And so be aware that it may affect some students in some ways different than others. It may affect their learning. It may affect their social or psychological well-being. So be aware of that and how it might play out into the classroom. So know that documentation is critical. It may affect the students' learning, but it might not. An epileptologist is a neurologist that has gone through additional training in the focus of epilepsy, and they can be really helpful with fully understanding the epilepsy that that student lives with and the best treatment path. And so if they have failed medications, if their seizures are controlled, but they're are uncontrolled, or the student has status, or if they're having a lot of memory or learning deficits, those would be reasons why they might see an epileptologist. There can be an association between seizures an epilepsy and their self-image or self-confidence, or they might feel some shame or embarrassment, although we know that they shouldn't, and we want to encourage students to feel confident in who they are. We understand that epilepsy may impact them. So it can affect their self-esteem, or it can lead to anxiety or delayed social development. And so wanting to make sure that we recognize all of those possible correlations that might exist. And it may, they may have comorbid conditions like ADD or ADHD. Their medication side effects might be impacting them in the school setting. So they might need things retaught or extra time. Not all their school difficulties are epilepsy related, so keeping that in mind. As a school nurse, recognizing seizure activity and its impacts are critical, ensuring appropriate seizure response is given, ensuring the student is allowed to fully recover as they're needed, and then coordinating ongoing treatment with the student, the parents, the school, and the healthcare team are all important aspects. And then training teachers and other school personnel to recognize and respond to seizures. You can utilize the Epilepsy Foundation of Minnesota to provide that training to both staff and students. And sometimes nurses are delivering some education on their own in the school setting. We are always glad to partner with schools to make sure that school is prepared, that especially when there's a student identified who's having seizures, sometimes they want that education, they're asking for it, maybe they are comfortable talking about it with their peers, and we can help facilitate and support that conversation and that awareness and understanding in the classroom. So helping to create an environment in which a child continues to achieve educational goals and minimizing the stigma. So we can educate, as I mentioned, on what we talked about today. We can address and prevent bullying and teasing when possible by being proactive and educating. We can teach coping strategies for managing life in school and help enhance independence and address parental overprotectiveness. So there's a lot of great things that can come from the school nurse being supportive and reducing stigma and being a resource. Put the family in contact with the EFMN or your local affiliate if you're not in Minnesota, and any other resources that might be helpful to the family. So the importance of Seizure Smart training, it helps enlist the full cooperation of the school personnel and family. It enhances the ability to manage seizures and the outcomes that could come along with that, and it ensures full integration of the student in school activities with appropriate accommodations, so recognizing the needs that that student might have, and it minimizes the stigma. And so we have some resources that are available that you can find online, including this short video for elementary age students and this other video that can be used with middle and high school age students. We provide free one-on-one support through our information services with customized tools and resources on a variety of epilepsy related topics, and materials can be requested at any time. You can find our link to our webpage here where you can request any of those resources or support. You can also see here our mission statement is that we lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. You'll see here that there is a link to our evaluation that you can fill out. There's a link if you are interested in donating to the Epilepsy Foundation of Minnesota, and my staff contact is listed here, so you can find my phone number and my email address listed, and feel free to reach out. I'm always glad to provide any additional follow-up or resources to help, and we can schedule a phone call, a virtual meeting, or whatever works best to follow up. References are listed here.